this is about remote risk awareness of COVID-19 outpatients. And you might ask the question, well, why would we use BPMN to design something like this? And this factual answer is that people in clinical healthcare use and change and generate data. And if you don't include them as part of your design, then what you're apt to get when they perform their behavior is an unpredictable response to the hardware and the software. Now, BPMN has explicit representations for people's activity in computing to help design. And we'll just drag this over here, get out of the way so you can hear. We've got this lane for the clinical personnel. We've got cloud AI in this lane, and we've got the patient and caregiver at home. And so this gives us an opportunity to actually include everyone in the design. Now our demo objective, let's get this right here, is we want to show how the shared data model of the BPMN field guide can specify the semantics of what we're going to define as risk awareness as a computationally independent model that's going to allow us to do functional integration of people and then verification of the design correctness of that integration. The clinical care problem that we're trying to solve, well, there's a dilemma when a doctor's patient tests positive for COVID-19 and they're a mild patient. They haven't really got any symptoms going yet. Ordinarily, for a serious disease like this, patients would be admitted for observation, but there can be a scarcity of available beds that might be needed by more severe cases. And then there's also the transmission risk of bringing more people who are infected into a clinical environment. So existing systems, in particular Mayo Clinic and Mass General, have deployed systems for what's called remote patient monitoring. And we think that designing a system around a BPMN workflow with a computational independent model can offer several advantages in terms of integrating AI, making everyone's behavior explicit, and improving patient safety. The functional purpose of remote patient monitoring is to provide clinicians with actionable risk awareness. That's abstract and it needs a lot more intuition, a lot more definition than just intuition. So we adapted Medicare's 4-point severity of illness DRG ratings to model the severity of the patient condition and the needed level of care. So for example, a severity level less than 2 is considered mild and home care capability is less than 2, and that would typically be appropriate. So there's an inequality that we can use to define elevated outpatient risk due to being at home as when the severity level becomes greater than the home care capability level, or when it's trending to become greater. Now, using this definition, we can expand it into a computationally independent model that represents the cognitive work problem of establishing and maintaining risk awareness. You can see at the top the patient enters with a positive test. If the exam finds that they've got a severity level that's higher than 2, then ordering admission is appropriate. If it's less than 2, then putting the patient in appropriate home care with remote patient monitoring is appropriate. Now, notice that these guard conditions are technologically independent. It doesn't say who's going to decide those numbers, who's going to generate the data. It just says this is what has to happen. What this allows is that this computationally independent model of the problem that has to be solved can be shared by any technology or any people that are capable of satisfying those guard conditions. Now, if the patient's in appropriate home care, then they can stay stable, and after a while they can become qualified for discharge, and that's a happy path. But if their trending severity level begins to exceed the care capability level, or if it's predicted to, then you don't want to get this patient in elevated risk, because there's a direct path from there to a fatality. So there's a couple of choices that can be made. One is that you hold an exam and admit the patient. The other one is that you could find some way to return that equality between the needs of the patient and their severity level and the capability of the home care.
10 minutes, Keith.
Thank you. So here's the workflow of PHware, and I'm going to walk through that. This is right down here. After the doctor orders home care, then the patient gets the PHware and starts following orders, and this is the device that can be used. It's like a thimble, and it replaces multiple devices with a single inexpensive and non-invasive finger clip. It senses data within a single session, and so it becomes a wearable streaming data vital signs device. It's used near a smartphone, and it uploads the data to an AI server. Now, here's the AI server. It exploits the power of computing. With machine learning, it actually assigns the quantitative values to the sense data, and preliminary accuracy is reaching levels for medical use for these 7 vital signs. Now, there's also an analysis predictive model that generates this trend, and if the severity level or the existing severity trending level is greater, then it throws an alert. Now let's go up here, and this model is of the decision-making authority of the clinician, and if there's an alert that's thrown, it bypasses any delay and goes directly here where it's reviewed. Here is okay. Gosh, I'm going to have to pull this up. Okay, so here's the home page of the specialized dashboard. And what you can see is that it's sortable list, and the patients with alerts have been percolated to the top. All the provider has to do to observe the data that justified the alert is take a look there. And so this gives the provider the decision authority that's needed. If it's confirmed, then a scheduler sets up an urgent exam. Now, there might be reasons that it's not going to be confirmed. For example, there could be more serious patients that are already in the queue, or there might be an exam that's already scheduled, and so there's no need to schedule an urgent one. And this gives the provider all the authority that they need. Down here is the more routine case. Now, all of this is very complex. So we undertook model checking of the correctness of the integrated design. The functional design, it's integrated, it's remote, it's asynchronous, and model checking was invented to prove the correctness of complex design. It was the technology achievement of the ACM Turing Award. So the SIM is a system property that allows us to extend model checking to PHware's joint human computing system. And the BPMN was translated into a language called Promula. That's why we use the basics of BPMN. And the spin model checker used the sim as the property to check, and you can see the results down here. What they mean is that the design, the model checking proved that the integrated design is correct to establish and maintain risk awareness in all its states and sequences.
5 minutes, Keith.
Okay, thank you. Well, here's our conclusions. BPMN can be made much more powerful with the shared data model of the field guide to specify the semantics of risk awareness as a SIM. The technology independence of the SIM allows it to serve as a well-defined shareable work object, and the functional integration of people in computing can be designed by coordinating their shared work on this technology independent model. Now, the SIM also provides a new type of evaluation criterion to extend model checking to prove the correctness of joint human-machine teaming. And this means that BPMN has important potential as a design environment to enhance patient safety. For questions about this that go beyond the meeting session, you can see the emails and the responsibilities. And we want to thank Steve White for his expert BPMN advice, Jaiji Zhang for serving on our advisory board, and Teresa Zayas-Caban for the AHRQ grant that sponsored the earlier work on these computationally independent models. We have time for questions.
One question for me, Keith, it's Denis. Have you deployed that in test environment yet, or is this limited deployment?
Ali, do you want to answer that question?
Yes, it is limited deployment, as Keith mentioned. So we have verified and validated via simulation, but it hasn't been fully deployed.
Okay, thank you. And Mark Nielsen, do you want to ask your question verbally?
Yeah, that'd be great. I'm curious about your AI model, model means different thing here, but your AI algorithm, is it just hosted as like a RESTful service on a cloud tool? Is it like a Python or R model? I don't know if you had details you'd be willing to share about that.
Yeah, I can quickly go over that. Yes, it is a RESTful server which run Python. And there are two levels of AI cloud server. One is for signal processing of the vital sign and vital sign estimation. And the other one is the higher level for the firing alert and things in that nature. Yeah.
Awesome, thank you.
Well, because we're among geeks. So what did you use for that AI model? Is it just a regression model, or do you have some deep learning going on? What's the basic of your model?
So for the signal processing, it uses machine learning. Actually, we are using ensemble of algorithms. And the data basically captured from 2,200 volunteer. So we use that for training the system. For the advanced, for the AI cloud analytic, yes, it is regression.
Thank you. Any more questions for the team? No? Well, thank you, Keith, Ali, and Eric. That was great. That's another great piece of implementation of the BPM Plus Health standard. So we have